today's deep dive. If you're tuning in, we already know a little something about you.
Mm.
You are the kind of person who, loves to stay ahead of the curve. You like to peer around corners and figure out how different pieces of a really massive puzzle fit together before anyone else does.
Right, the early adopters.
Exactly. And today, our goal is to figure out how hospitals are navigating this monumental transition. They're moving away from a reliance on reactive data dashboards and toward a model of proactive, human-led clinical intelligence.
It's a fundamental operational shift. I mean, for years, the absolute gold standard in healthcare management has been the dashboard.
Yeah.
You open a screen, you look at your quality metrics, you review retrospective reporting, and, well, you make decisions based on that. But that model is hitting a wall.
It really is.
And the reason is actually quite simple. Dashboards only tell you what has already happened. By the time a patient's adverse event shows up on say, a 30-day readmission report, the physical damage to the patient and the financial damage to the hospital are completely done.
Okay, let's unpack this. Because the core issue here is that healthcare leadership is essentially flying on delayed data.
Yes.
By the time a situation on a medical surgical floor escalates and finally hits a director's desk, that preventable ICU transfer has already become a massive, unchangeable line item on the hospital's P&L statement.
Right. If we connect this to the bigger picture, the real question facing healthcare systems right now isn't about how to get better, more granular data.
They already have mountains of it.
Exactly. They have mountains of data. They have algorithms processing thousands of data points a second. The actual problem to solve is how to act before that data needs to be collected in the first place.
Right.
Because once the data point exists, once the code blue is called or the transfer is initiated, the toll has already been exacted.
It's basically the classic rear-view mirror problem.
Oh, that's a good way to put it.
You have high-definition visibility of every single pothole you just hit, every swerve you made, but absolutely zero visibility of the road ahead. That massive financial exposure comes from driving blind.
And that blindness has a very specific, crippling price tag. When you look at the recent clinical research, specifically the 2023 PMC studies and the 2025 Oxford academic research on critical care, an unplanned ICU transfer adds an incremental $21,000 to a single patient's case.
Wow. $21,000.
$21,000 above their standard admission cost, just for that unplanned move.
Just to put that into perspective for you, an unplanned transfer isn't just a change of scenery for the patient. It's a massive mobilization of hospital resources.
Right.
It requires moving them to a unit with a 1-to-1 or 1-to-2 nursing ratio. It means ordering rapid response diagnostic panels and often initiating really aggressive, high-cost pharmaceutical interventions.
Which is exactly why the financial bleeding doesn't stop at the transfer itself. Then you have to factor in the length of stay, or LOS.
The daily costs.
Exactly. Every single additional day a patient spends in the hospital costs between $2,200 and $3,800, depending on how sick they are.
And that adds up incredibly fast.
It does. When there is a delayed escalation, meaning a deteriorating patient isn't spotted in time, it consistently adds 1 to 2 totally avoidable days to their stay.
You start doing the math on just those two metrics, a $21,000 transfer plus potentially $7,000 in avoidable days, and the numbers just become astronomical.
Yeah.
But we can't just talk about the balance sheet because the human cost is the driving force behind all of this. Take sepsis, for example.
Sepsis is the perfect lens for this issue. It's not only the most expensive condition treated in U.S. hospitals, but it's also the leading cause of in-hospital mortality.
Which is terrifying.
It is. In critical care, there's something known as the 1-hour bundle compliance window. It is an incredibly narrow time frame. The moment a patient meets the criteria for sepsis, the medical team has exactly 1 hour to draw blood cultures, administer broad-spectrum antibiotics, and start intravenous fluids.
And every minute past that hour is a dangerous slide. Every single hour of delay in recognizing and treating sepsis actively increases the patient's mortality risk. It drastically extends their length of stay and creates severe financial exposure for the hospital under Medicare quality metrics.
And that ticking clock is exactly why the retrospective dashboard is so dangerous.
Because it's too slow.
Way too slow. If you're waiting for a software monitor to refresh or a delayed lab result to finally flag a patient as septic, you have almost certainly missed that 1-hour window, which leads directly to a very grim, recognized patient safety indicator called failure to rescue.
Let's define that term for a second, because failure to rescue sounds intense.
It does.
It describes a situation where a patient deteriorates and the medical team simply doesn't identify the warning signs in time to intervene. The safety net fails. Not because the treatment didn't work, but because the opportunity to provide the treatment was missed entirely.
That is the ultimate consequence of the rearview mirror approach.
Yeah.
You simply cannot dashboard your way out of a failure to rescue event in real time. A spreadsheet cannot assess a patient's skin color or breathing pattern. You need a different kind of mechanism entirely, a forward-looking sensor, to catch these deteriorating patients before they become a statistic.
Here's where it gets really interesting. So if the dashboards are fundamentally lagging, what actually bridges that gap?
Human intelligence.
Exactly. You'd think the answer is just faster software or better AI predictive algorithms, but the solution presented in the proactive clinical intelligence model is entirely human. It involves deploying what are called ICU-experienced stat nurses.
And we need to be very precise about what this role actually entails. When people hear about an experienced nurse catching a problem early, there is a tendency to write it off as nurse intuition.
Like it's a gut feeling.
Right, as if it's some sort of magical sixth sense. It isn't. This is hardcore clinical pattern recognition. It is a highly specialized, deeply analytical skill set built from thousands upon thousands of hours standing at the bedside of the sickest patients imaginable.
So it's less about intuition and more about rapid subconscious data processing. These nurses have spent a decade or more managing hemodynamically unstable patients, where blood pressure and blood flow are actively crashing. They are experts at reading subtle lactate trends, which are key early indicators of cellular stress, and recognizing the absolute earliest microscopic signs of multisystem organ failure.
They are processing thousands of microvariables that a machine simply isn't programmed to contextualize.
Right.
A dashboard only reads the data it receives. A human expert reads the context surrounding the data. Because of that specialized experience, these nurses possess a staggering advantage over the machines. They can identify the difference between a patient who is compensating and a patient who is decompensating.
Let's break down that difference. A compensating patient is someone whose body is working in absolute overdrive to maintain normal vital signs. Their heart is beating faster, their breathing is shallower, all to keep the numbers on the monitor looking okay.
But eventually, they run out of energy and they decompensate. They crash. An experienced ICU nurse can spot that dangerous compensating phase up to 12 hours before a standard dashboard metric will finally drop into the red zone and trigger an alarm.
Oh, hours.
Up to 12 hours, yes.
In critical care, a 12-hour head start is an absolute eternity. We were just talking about a 1-hour window to save a patient from sepsis. If a human expert can give you a 12-hour lead on a deteriorating patient, that completely rewrites the rules of patient safety.
What's fascinating here is how this clinical intelligence is actually deployed.
Huh.
The model doesn't just keep this highly trained nurse locked inside the intensive care unit.
It sets them loose.
Exactly. It takes that elite pattern recognition and makes it mobile. It deploys the stat nurse as a roving, systems-aware presence across the entire hospital, specifically targeting the general medical surgical floors where patients are traditionally less monitored.
By taking that expertise mobile, you create a living, breathing, early warning layer. No current algorithmic dashboard can replicate that at the bedside. You're taking the most advanced sensor currently in existence, a highly trained human brain, and placing it right where the risk of a failure to rescue event is highest.
Let's look at how that operates on a Tuesday afternoon on a busy hospital floor. The core functions of this stat nurse are deeply proactive. They aren't waiting for a code blue to be called.
They're out hunting for it.
Precisely. They are actively rounding, performing proactive patient assessments, and hunting for the deteriorating patients before any escalation alarms are ever triggered.
They are running real-time sepsis surveillance right there in the hallways. They're reviewing those subtle lactate trends and pushing for that critical 1-hour bundle compliance before the floor nurse even has a chance to worry about it.
Right.
And that brings up a really crucial dynamic, the relationship between this stat nurse and the regular floor staff. Floor nurses are managing incredibly heavy, complex patient loads, often with 5 or 6 patients at a time.
When a floor nurse has a patient who just seems off, maybe their vitals are technically fine, but their color is wrong or their mentation has slightly changed, the floor nurse often doesn't have the luxury of spending 45 uninterrupted minutes assessing them.
They just don't have the time.
No, they don't. The stat nurse becomes an immediate, highly experienced resource right there on the floor. They step in, perform the deep dive assessment, and then act as a vital bridge to the physicians.
That bridge is everything. The stat nurse takes all those subtle clinical findings and translates them into acuity-based language.
Yes.
They know exactly how to frame the clinical picture using the specific actionable metrics that a doctor needs to hear to authorize immediate intervention. They aren't just saying the patient looks bad, they're saying the patient's clinical markers indicate impending respiratory failure, we need to escalate now.
Which naturally accelerates the physician's response time. But there is a very important distinction to make about the nature of this role. This is a clinical amplification role, not a supervisory one.
That is a vital nuance. The stat nurse is not walking onto a medical floor with a clipboard to check boxes, write up staff, or look over people's shoulders.
No, that would instantly kill any collaboration.
It really would.
It would completely undermine the model. Their entire purpose is to bridge the dangerous gap between a patient's scheduled assessments, say vital signs taken every 4 hours, and their actual real-time clinical deterioration.
Right.
By being that bridge, the stat nurse acts as a force multiplier. They make the floor nurses, the respiratory therapists, and the physicians significantly more effective without adding administrative burden.
A force multiplier that also happens to be a massive financial shield for the hospital. Let's dig into the return on intelligence.
The ROI.
Yeah, the ROI. When you run the financial projections on this model, the business case is undeniably compelling. And these aren't aggressive best-case scenarios. These are conservative, per-facility projections based on current healthcare economics.
The math is straightforward but powerful. Let's go back to those unplanned ICU transfers. If a single stat nurse rounding the floors manages to prevent just 3 unplanned ICU transfers in a month, just 3, that is $63,000 in avoidable costs instantly saved.
Then factor in the length of stay impact. If their early interventions, getting ahead of sepsis or respiratory failure, save just 10 hospital days per month across the entire facility, that avoids between $22,000 and $38,000 in unnecessary costs.
When you annualize those conservative baseline numbers, the projected impact lands between $1.4 million and $4.2 million in combined revenue protection and cost avoidance per facility every single year.
$4.2 million. And what does that kind of money actually mean for a hospital?
A lot.
In an industry where operating margins frequently hover around 1 or 2%, protecting $4 million on the expense side is the equivalent of generating tens of millions of dollars in top-line revenue. It's the difference between being able to fund a new maternity wing or having to freeze hiring.
Furthermore, those figures don't even capture the total financial footprint. They completely exclude the secondary benefits.
Like what?
The immense cost savings from improved staff retention because floor nurses feel supported instead of abandoned, the reduction in 30-day readmission penalties, and the massive downstream value when this proactive model is scaled across an entire multi-hospital system.
So, what does this all mean for a hospital administrator listening right now who wants to implement this tomorrow? You can't just throw a generic job posting up on an internet board and expect to build a $4 million safety net overnight.
No, you definitely cannot.
This requires a very specific type of professional. The ideal candidate profile for a stat nurse is, frankly, a unicorn.
Unicorn is the most accurate description. This is absolutely not an entry-level position, and trying to scope it or compensate it as one is a recipe for failure. To actually deliver those financial and clinical returns, the candidate has to seamlessly bridge 2 entirely different worlds: the high-stakes, life-and-death environment of intensive care and the complex, metric-driven operational language of hospital administration.
The required pedigree is intense. We are talking about 15-plus years of direct ICU-level clinical experience.
At a minimum.
Yeah. You simply cannot fast-track the kind of pattern recognition needed to beat a computer by 12 hours. You only get that from years of managing the absolute sickest, most complex patients in the building.
In addition to the clinical hours, they need current hospital-wide operational experience. They need to have served as a charge nurse, an administrative officer of the day, or a code team leader. They need to possess a proven systems-level awareness of how a hospital actually moves patients and resources.
And perhaps the hardest skill to find, they must have the demonstrated ability to translate clinical outcomes into financial and quality metrics. They have to sit in a boardroom and speak the language of the C-suite just as fluently as they speak the language of the ICU. They need existing, trusted relationships with physicians across multiple service lines and a track record of developing workflows that actually get adopted by tired staff.
But even if a hospital manages to recruit this unicorn, the individual alone is not enough. You cannot just drop a highly trained expert onto a chaotic medical floor and say, go save us money.
That never works.
Never. There has to be a rigid, protective governance model in place to support them.
Without structural support, even a unicorn gets bogged down in hospital bureaucracy. The operational reality requires 4 key governance pillars. First, the role must be formally recognized by hospital leadership, with a clearly defined scope of practice and clinical authority.
Second, the stat nurse's work must be directly tethered to the hospital's clinical quality and safety committees. Their findings need to feed directly into systemic improvements.
Right.
Third, they must be equipped with frictionless, real-time documentation tools to capture their clinical interventions exactly as they happen.
That documentation piece is crucial. It creates the permanent data trail that hospital leadership needs to justify the program's existence and make evidence-based resource decisions later.
Exactly.
And the fourth requirement is having absolute unwavering support from physician champions and nursing directors. Leadership has to understand the operational function of the role and defend it as a collaborative model, ensuring the stat nurse isn't dragged into parallel authority conflicts with unit managers.
Ultimately, all of this preparation and investment comes down to the broader landscape of healthcare economics right now. Under the Centers for Medicare and Medicaid Services, CMS, the evolving value-based purchasing framework is fundamentally altering the financial incentives for hospitals.
It changes the whole game.
It does. Leaders are simultaneously being asked to protect razor-thin margins, drastically improve quality scores, reduce preventable adverse events, and retain burned-out experienced staff.
The reactive data model, the rearview mirror approach we discussed at the beginning, that was designed for an entirely different era of fee-for-service reimbursement.
Yeah.
Today, hospitals are increasingly penalized financially for what doesn't happen on time. They're penalized for readmissions, for hospital-acquired infections, for those failure to rescue events, and for preventable complications.
Which forces a radical change in perspective. The margin is now entirely in the prevention, not the treatment. If you are waiting for a patient to get sick enough to require complex treatment, you have already lost the margin.
You're just paying for the damage.
Exactly. Therefore, the ICU experienced stat nurse cannot be viewed as just another nursing labor cost center. In a value-based care environment, this model is a mandatory revenue protection strategy.
It is a profound